So I will talk about the topic, the US guided tissue acquisition. And in my opinion, um, there is no an advanced endoscopist that did not publish in this topic. And I would say if you review data in a topic like that, you will just like be bombarded by trials after trials after trials. So the goal of this lecture is to keep it very focused in certain important point that we need during tissue acquisition. So tissue acquisition came with linear ultrasound, and we know with linear array we're able to see the lesion, and also we can advance the needle under ultrasound guidance to obtain biopsy. Um, Initially, when EUS was introduced in the 80s, people were thinking about it as a diagnostic utility just by looking and staging tumors. And later on, we learned that moving from radial to linear ultrasound, that we can also do EUS FNA. So what do you need to perform tissue acquisition? You need echo endoscope. Sometimes color Doppler is important because you want to differentiate blood vessels in your path and stay away from them. Aspiration needle or forceps, intramural lesion, organ outside of the body, and the cytology and histology. And this is how this process is. We're going to go a little bit through all methods of tissue acquisition. And I chose this word, tissue acquisition, instead of saying EUS FNA, because tissue acquisition is more broad than FNA. We have FNA, you have fine needle biopsy, FNB. Now we also have through the needle microforceps, and we also have the EUS virtual biopsy. It's not really an actual biopsy, but we do have virtual biopsy using NCLE, which is a microscope. So because there is a lot of published data and a lot of opinion, and I trained at Mayo Clinic in Jacksonville, and I was fortunate to have 3 physicians training me in EUS. One of them was Timothy Woodward, and he was doing EUSs from 1986. He was one of the initial people who got the radiologists to help him learning EUS. Then I was also trained under Massimo Raimondo, who's Italian from Palermo, a very well-known pancreatologist, and he was trained in a certain way. And then I had Mike Wallace, and Mike Wallace, who was trained under Bob Haas, and it's a total different school in EUS. And the 3 of them would perform EUS in totally different way. And the 3 of them would have their own method of doing it, and other methods are wrong. And I would have to learn, if I'm working with Wallace, this is how I'm going to do it. If I'm going to work with Raimondo, this is how I'm going to do it. And that led me for a lot of time to look about different techniques, what's better and what's worse. And what I learned is that there is a lot of myth in the EUS tissue acquisition field. There's a lot of things we're doing that we believe that it is really the right way, but there could be other ways that is better. One of the time I remember I was doing EUS FNA with Mike Wallace and going like very quickly, the way he stabbed, he called the stabbing technique. And Massimo Raimondo came to the room and he got so upset. He told me, this is not how I taught you to do EUS FNA. So, and this happened in our unit. Dr. Patel, he's my partner. It's the same thing. He has different style than my style. When we teach our fellows, we try to tell them that there's many ways of doing things, and that's what I'm going to show in this lecture. So let's talk first about the role of stylet. A lot of people say provide stiffness to the FNA device, prevent clogging of the needle with the digestive wall tissue while puncturing, prevent the contamination of the sample by the cells that do not originate from the intended target lesion. So basically, having the stylet in your scope will allow you to push that tissue out when you get with the tissue puncture, and then when you do FNA, you will not find contaminant. If this is true or myth, and anything here I will highlight with red is just like a question. Does really prevent the clogging of the needle? In my own experience, I don't think it does. So this one of the published trial comparing the stylet versus no stylet. And here we're showing that the cellularity is not different. Adequacy specimen is not different. The contamination, because this will always talk about, oh, if you use a stylet, there will be no contamination. There's no difference whether you use a stylet or not in terms of the contamination or the amount of the blood. This was published by my friend Sachin Wani in 2012 in GIE. There is other articles looked at stylet versus no stylet. Guidelines would say no need to use a stylet. So in a way, to me, this was a myth that you have to have the stylet. Well, I'm doing it. Yes, I'm doing it. Well, our technicians spend the time trying to put the stylet again? They do. But when I think about it, it is waste of time. It's also waste of effort, and it's also you can get injury, because sometimes this the needle stick or the stylet can injure the finger, and it did happen before I saw it happen to one of our technicians. It can pierce through the gloves and so sometimes maybe you have to think about what you are doing and why you are doing it. Another thing, the use of particular FA needle. So every one of us have that needle that it is the best. And if you are in training and you would know you work with this doctor, he will use this, you work with that, he'll use that. But honestly, most of FNA needles in the market are comparable. In my opinion, the preference of one needle over another is usually a physician preference, and it is mostly due to physical aspect of each needle. So in reality, if you really think about it, when you find that you prefer one needle over another, it's most likely because you like how the handles feel, or you like how it is easily going into the tissue. And I know it is very hard to say that, but I tried it myself on myself. So I had a specific preference of one needle, and I was firmly believed that one of these three needles here performed better than the other because I was trained with it, and it was the one in the market for a long time. So when I went out in my practice, one of my first studies I did in 2012 to 2015 is that I compared three needles, Easy Shot, Expect, and Procore from three different manufacturers. And the way we did it, it was very well designed, prospective trial, cellularity score done by two pathologists. Both of them are blinded. They don't know the needles. They don't know what we are using. And both of them will score differently, and we get their aggregate score. And we created cellularity score, looked at the blood score, and also looks at the freeze and inflammatory cell, and also the amount of neoplastic cell. And honestly, we found no difference. Both of the scores and everything, as you can see here, the p-value was similar in all needles. In my practice, while I was doing the study, I had a specific preference to one. In my mind, I was thinking this needle is providing the best tissue for me. But when we did it in a study, we found there's no difference between the one I like and the one I don't like. So the fact that all needle, FNA needle, most one available in the market, perform accurately, I agree. And I think there's more than just a needle you're using. It's more about the technique, choosing where the lesion is. And I would say that because I know we have a lot of our attendees here who are just starting to do EUS, FNA, and it is the location of where you put your needle. And when you see a lesion, you want to go to the most hypoechoic part, but also avoid necrotic area. Because if you go into necrotic area, you're going to get non-viable tissue and you will not get diagnosis. So always try to start in an area that you think it is not necrotic. So yes, it is hypoechoic, but not deeply hypoechoic or cystic that has cystic degeneration, and you cannot get good biopsies. So another one, fanning technique. A lot of people talks about standard versus fanning technique. A standard technique, you just stay, as you see in the video, in one location, and you go up and down, 10 uniform to and fro needle movement. And that's a standard of care, one in and out 10 times. And you can either go fast when you're going in, slow when you're coming back. Some people do that, and some people just continue slow in and out. Fanning, though, you will try to address different location in the lesion. And how you do that, it's using your dial up and down. So you are using either the elevator or the dial, and you use the big dial up and down while you're doing the FNA. And that will allow you to move your needle into the tissue in different area. Some people believe that fanning technique is superior to standard technique, and they will teach it, and they'll teach the fellows. And I teach the fanning technique to my fellow. Whether this is true or not, there's many studies about fanning versus no fanning technique. And we can see here the diagnostic accuracy in the study that was published by Varajululu in 2013 and his group. And it was a small study, but it was prospective and well designed. And I chose here, there is a lot of retrospective data, but I tried to choose mostly prospective trial that was well designed from trusted groups. And if we look at that study, when they looked at fanning versus standard, there was no difference in diagnostic accuracy, but there was a very interesting phenomena, which is that the diagnostic accuracy of the first pass was way higher in the fanning technique. You may not need a second or a third pass. And because you don't need a second or a third pass, you just have low number of passes. So the conclusion of this study was that fanning technique will allow you to do less number of passes. Although that's true, I worry sometimes about increased bleeding and increase with fanning technique. So you can use it, but within range. In reality, I feel like at the end of the day, the diagnosis is similar. And with the new with FNB technique, this may not even be relevant, as we're going to talk about that a little bit later. The next topic, suction versus no suction. This is something also people are very interested in. And basically the idea when we started FNA as a standard technique is that you apply negative pressure. And by applying negative pressure, you're going to increase the amount of tissue that's suctioned. And the negative suction, though, when you suction too much, you're going to see more blood. So is the diagnostic accuracy of EUS FNA with or without suction is the same or not? I think, and most people will believe it is the same, but we're going to examine that. But before we go to the next slide, I want to talk about the concept of nowadays of FNB and FNA. In FNA, or fine needle aspiration, you are trying to look for cells. And when trying to look for malignant cells, you don't want a lot of noise around it. You don't want to have a lot of blood. So applying too much suction will increase the blood. It may make cytology not that clear. In fine needle biopsy, though, you are trying to get core tissue and core sample, and you're trying to get actually core tissue, and maybe doing suction will make difference. And that fact is very important to understand all the published data about suction versus no suction. So overall, in this study in 2008, they used suction for fibrotic pancreatic lesion, and they looked at suction versus no suction, and they found that sensitivity is higher, specificity is good, and the accuracy is significantly higher than no suction, 92%. But in that study, most of this patient was having pancreatic lesion that's fibrotic. If you are doing it in a lesion like lymphoma, for example, and you do too much suction, you're going to get a lot of blood. So suction versus no suction is not a standardized technique for everything. It all depends on what you are sampling. So yes, in terms of fibrosis, you're going to use suction. If you have a vascular lesion, suction may not be good. There's another study comparing standard suction technique versus a slow pull technique, and that's recently got published as a Korean study. They compared 96 patients, and they found here that the slow pull technique is much better than suction in terms of getting higher diagnostic accuracy and true positive rate. So what is a slow pull technique? And I have one of my partner, Isaac Reichman. He is really interested in this technique. And I also think Dr. Kalbatel loves that technique too. I don't use it a lot, but what they do in the suction and the slow pull technique is that while you're doing FNA, you're asking your assistant to just pull little bit by little bit your stylet. And by pulling the stylet up little bit by little bit, you're applying negative pressure enough to suction the tissue, but also you are providing a space, control the space for the tissue to come in, and then the space will become compact and the tissue get compacted, so you can get a like nice amount of tissue. Some people prefer that, the slow pull with fanning technique versus standard suction. I think right now it's becoming almost a way of doing EUS FNA, that you'll just do slow pull and fanning in the same time. And by doing the slow pull, you are decreasing the amount of blood that could be resulted from the fanning technique. So if you will ask me which from all of these, I will say the one right now that people prefer or it's yielding high result, I will say do slow pull, but also do fanning together. Then you're going to yield better results. Then the heated topic, rapid on-site evaluation, rows versus no rows. You get hired as an advanced endoscopist out of fellowship, and you go to this place in, for example, private practice hospital, small university practice, and the first request to them, I need a histologist or pathologist, or I need a cytology technician to come to do rows. In some places that's feasible, in other it is not feasible. In my first job at Texas Tech University, they made the pathologist came. And at that time, I was lucky to have a pathologist to come. But in reality, this doesn't happen. You're not find people coming to your unit all the time. So I came to Baylor College of Medicine, and all of a sudden I have no rows. And then I told them I need rows. I have been doing rows forever. And they said, nope, there is no rows. We cannot do it. And that's it. And then it was for me a tough life, rows versus no rows. Actually, before I go to Baylor, I was convinced that you cannot do EUS FNA without having rapid on-site evaluation. But with time, I learned that we don't need it. So why people think rows is important? Because you will have somebody in the room who will tell you right away, this is like if you have enough tissue or not. It decreases the number of needle passes needed to obtain diagnosis. It will improve your diagnostic accuracy. So meta-analysis 2012 and looked at 333 studies, and this show you how this rows versus no rows is very important topic to a lot of people. 4,989 patients, and the pool sensitivity, yes, rows the sensitivity was 88, but without rows it was 80%, but there was no statistical significant difference. Maybe the statistical significant difference will be better for center who have very low yield. So for somebody who's just starting, who doesn't really know if he's doing a good job or not, you may need to get rows. It will help. In places when people are doing this procedure forever, you know, somebody like Professor Okashef is doing it, or Professor Hakan, like, I don't think they will need rows. If you are somebody just starting, having rows will help you. I would say when I was attending out of fellowship 10 years ago, rows was helping me because it was giving me instant feedback about my performance. Can you get this feedback without rows? You can, but it will be 2 days later when you get the pathology result. So in a way, rows would help somebody who's just starting, who have a lower sensitivity and lower diagnostic accuracy. If your diagnostic accuracy is already above 90%, it may not make a difference. So now we're going to go to the next topic, FNA versus FNP. So in a way, we evolved from using the fine needle aspiration needle into a larger needle that can obtain core tissue. And that was started with one needle, Procore. And then after that, we heard about two other types of needles that came to the markets, and both of them perform actual FNB, which allowed us to do things we were not doing before. So why you need FNB, and what is the rationale of FNB? I will tell you where I practice at Baylor College of Medicine. The rationale is personalized medicine. Our oncologists ask for it. They will tell us you have to do it. And if we don't do it, they are not happy. Why they're not happy? Because they want tissue. And why they need the tissue? Because it will help them for two things, either immunotherapy or immunohistochemistry for IHC chaining. You cannot do IHC on cells. You need actual core tissue. You would argue that if you do a good FNA, you are going to have enough core that you can do that. That's correct. But we found that with FNB, we actually can do that with no problem. There's certain tumors too that you need enough tissue architecture to get the diagnosis. So if you do have FNA lymphoma, you're going to get pathology results saying there's abnormal cells, but I cannot diagnose lymphoma because we're seeing cell. To diagnose lymphoma and know if it is T cells or B cell, you need to have tissue architecture. So using FNB will provide this frame, provide nice core, and which allow us to make the diagnosis. The same for autoimmune pancreatitis. A lot of time, autoimmune pancreatitis will not be diagnosed with FNA. You're just going to see some inflammatory cells. Having this FNB will help you. And right now, too, with liver biopsies, it's opened a new rule. I think my partner, Dr. Patel, will talk about what he's doing for EUS guided liver biopsies and EUS hepatology, but it was an uphill battles. For a long time, our hepatologists were believing that EUS FNA cannot work for liver lesions. Why is that? Because from prior experience, 15 years ago or 15 years ago, our EUS FNA was not providing a nice a strap of tissue like the one they would get from PTC, from not from liver-guided skin biopsy, percutaneous biopsy. Now with FNB, we are able to provide as good results as percutaneous biopsies, which is something it's new. So that's why we're more passionate about FNB. And also doing FNB, you don't need to do rows. Once you have FNB, really there's no need for rows. You're getting a and what we do is totally different when you have FNB, as I'm going to show later. So that's a meta-analysis that done by Todd Byron. It was published in Endoscopy International Open, and basically they looked at all the studies about FNB versus FNA, and they found that FNB is not superior to FNA in terms of diagnostic accuracy. So if you just want to get diagnosis of pancreatic cancer, it is the same. So why you are using FNB is not for diagnostic accuracy. We had a very good diagnostic accuracy before we use FNB with FNA. We're using it for personalized medicine. And that's a message I want to get for this lecture about tissue acquisition, that FNB, although it is the same as FNA in getting diagnosis, you're doing it for the other potential application to it. So what do we do at Baylor St. Luke's? At Baylor St. Luke's, we only use FNB needle. That's it. We stopped doing FNA. We only use FNA needle for other applications, maybe for pancreatic cyst, but for tissue acquisition will be FNB needle. And even for pancreatic cyst, we do cyst wall biopsy with FNB. So mostly we are doing FNB, 95% of what we do. We also are very bold. We send our sample in formalin, and we just did a study that we're showing in the left here, showing actually why we even need to send anything for cytologists. And let me give you a little bit background about that. In every large university, you will have the pathologists who are surgical pathologists who would work on the specimen that you send from the colon and from the stomach. But you also have the cytologists, and mainly they had an extra year of training in doing cytology, maybe samples from the thyroids and cervical sample and other organ. The cytologists are trained to look at cell. Pathologists are trained to look at tissue. Cytologists would like to get the sample in preservative, usually certain type, and in ours they like cyto-rich media and cytolites sometimes, and pathologists would like formalin. So what we do in our unit for period of time, we do two passes using fanning technique, and we use suction, and no more than 2 passes, and we send one in formalin and we send one in cytology. And that's the result of 1 year of doing that, of 122 patients. And what we found here for pancreatic cancer, the difference in diagnosis was not that different. None of these was statistically significant. So both of them, either in formalin and cytology, is the same. So what we do now, we just use FNB needle, we put it in formalin, and we send it for the standard pathologist. We believe this will have an impact in places like in smaller hospitals, and also in places when you don't have rows available and when you don't have cytopathologists available. Your standard pathologist who read your biopsies through the stomach can also read your FNB needle. They can be trained to read your pancreas. And we think we need to simplify the process of doing FNB or obtaining biopsies using EUS and make it easy, accessible, and available to a lot of people. And by using FNB, we are achieving that. And that's what we have been doing now for the last 3 years. And FNB, or doing EUS FNA, a process or procedure which used to take 45 minutes in the past, now it is 10-minute procedure. We identified the lesion, doing the staging, doing 2 biopsies, and we move on. So this also, FNB allowed us to do things we didn't use before. That's an example, patient with gastroparesis. They have lots of interstitial cell of Cajal. For studies of gastroparesis, the only way to diagnose this patient is to do full thickness biopsies. That's a study we published in 2016, and we compared doing FNP versus surgical biopsies. And these patients were going for gastric neurostimulator placement. And before their gastric neurostimulator placement, by 24 hours, we did an FNA. And within 24 hours, they had a surgical full thickness biopsy. And that was an amazing opportunity to compare FNA to full thickness biopsy of the stomach. And we find a great concordance rate in most of the patients. Basically, in this 11 patient, EUS FNB versus surgical biopsy, there was no difference. It was also so interesting to look at the damage that happened in the wall when you do EUS FNB, because a lot of people worry about the EUS puncture. And as you see here, is mild serosal inflammation where the EUS FNB sample was, nothing more than that. So in a way, this is another proof that EUS FNB is safe. And although the needle may feel a little bit stiffer, it's still producing no serosal tear and no perforation. The new kids in the block is the EUS through the needle microforceps. Is a microforceps, so you put a 19 gauge needle. cyst wall biopsy. As we see here, there's a large pancreatic cyst in the head of the pancreas. And what we're going to do is to try to identify a passage through the EOS-FNA needle. And once you introduce your needle inside the cyst, now we're going to advance through the scope microforceps, and you can feel, and you're going to see once you get the tissue, how the cyst wall will come towards you, and how right now you'll be able to get the biopsies. And that's the end result. As you can see here, we're able to visualize the cell lining of the pancreatic cyst under the microscope. And we started this technique and we're very skeptical about how successful that would be. And I would say it really helped us to make the diagnosis of many pancreatic cysts, and helped us to reach to a point that right now, with a lot of certainty, we're able to say if this cyst is precancerous or not. I'll show here our data and initial data 2 years ago on 16 patients with cyst size of 2 centimeters. We had a 100% success rate, and we're able to obtain cyst wall biopsy 11 and 16 patients. Now are much better than that. And most common finding was IPMN, and it was enough for cytological evaluation in 50% of the patient. And it really helped us, the combination of through-scope forceps and FNA, increase the yield of diagnosis or sensitivity to 81%. There are some data about bleeding that could happen after this procedure. The good thing about pancreatic cyst is that once it's filled with blood, it will stop bleeding because there will be a tamponade effect. Last few slides about NCLE. It's a novel imaging technology utilizing focal laser scan for evaluating pancreatic cyst. The technique, as we know, emerged from France, and probably Dr. Giovannini and others in France published a lot in this field. And usually it's virtual biopsy. And right now we're doing, as you can see here, that's how IPMN, how it looks like in low grade, intermediate, and high grade. And when we do NCLE, we can see how high grade would look like and low grade would look like using the Cellvizio and NCLE. Right now we're doing CLIMB study at Baylor along with other centers in the United States to see if using this technique will really makes a difference in how we are diagnosing IPMN dysplasia. So last slide here showing low-grade dysplasia. You have less dark epithelium, regular border in the papilla. And if you have high-grade dysplasia, you can see the darkness increase, a lot of nuclei, very thick walls, and you can see the difference between them. It's very helpful. Recently, I did 2 NCLE patients, and one of them, the biopsy or cytology was not diagnostic. And then we did the Cellvizio, and we were able to see the same picture of high-grade dysplasia. Patient was sent for surgery, and she did have early cancer in this cyst. And I would imagine with more and more we get comfortable with this technique, it will also aid in our diagnosis of pancreatic cyst. So in conclusion, EOS-FNA diagnostic accuracy is improving. We have different techniques now. EOS-FNP could be useful when ROSE is not available in other situations, such as in personalized medicine, and EOS through the needle microforceps yield promising results in pancreatic cyst. Thank you.
Thank you, Professor Mohammed, for this excellent, concise, quite illustrative lecture. And I have a few questions, and also there is a question from the attendees. There is one question from the attendees. What is your indication for 22 gauge needle and 19 gauge needle? Do you prefer 22 gauge needle for endocrine tumor? This is one question.
Yeah, well, thank you for that question. That's a slide that I didn't add. And when I was like preparing it, I said, like, I didn't put the 22 versus 25. It is another different thing. In my opinion, 22 versus 25 wouldn't make a big difference. You know, our neighbors in MD Anderson, they only use 25 gauge needle for all pancreatic lesion. We only use 22 FNB, and we see that we have similar results. In regard to using 25 gauge needle for endocrine tumor, I think the reason for that is that it's less blood. You can do that. However, right now, we are always moving towards having a tissue. So we'd prefer 22 gauge needle FNP. I rarely use 19 gauge unless we're doing liver biopsy.
Yeah. The second question is from our colleague, Dr. Ahmed Al-Maligi. So what is the role of FNA needle? He asked if we are now going to use FNB. What is the role of FNA?
So FNA, well, there is a cost too. If the cost of FNA and FNB are the same, then maybe FNA is preferred. In certain situation, FNB needle could be a little bit, I would say, rough on the tissue. So if, for example, if you're worried about bleeding, you may use a smaller needle, 25 gauge or 22 FNA needle, if you're worried about you're close to a blood vessel or something. But in most of the, I would say 95% of what I'm doing right now is FNB. I don't know what about the rest of the panel, but that's what
Yes.
I do now with FNB.
I think Professor Hussein Okasha has a different idea, because Professor Hussein, as we learned from him, that even with FNA, we may get a good score, and the story is for the pathologist or the cytopathologist who is working, not for the endosonographer. So what's your opinion? And also I need the opinion of Professor Okasha.
Well, I want to, because, you know, again, there is many different opinion about that. And I think this discussion will be more interesting if we can have another opposite opinion about why FNA is important. So I would like to hear Dr. Okasha too.
Yes, that is a comment I'd like to say. Of course, most of the literature saying that FNB is better than FNA. This is no doubt. But in Egypt, I think there is a very important factor. A very important decisive factor is the professionalism and the cleverness of the cytopathologist. When I changed the cytopathologist to the best one, it is a cancer institute and saying hundreds and thousands of cases, the accuracy of FNA, usual FNA Cook EcoTip 22, very malleable, very manipulative, and our accuracy is about 92% over hundreds and thousands of cases. But in the presence of non-professional cytopathologists, I think FNB is better, no doubt, than that. But in presence of professionalism, I think it is a very, very decisive factor. Another situation when we are targeting small lesions, especially in the uncinate process. You can target it except in the deep part of the duodenum with upward deflection of the echo endoscope. So the echo endoscope takes a bending position or J-shaped position. So here the FNB is somewhat may not emerge from the tip of the echo endoscope, and then you need a more manipulative. But this represents about 5% of all FNA. And of course, it is less costly. But the company now is decreasing the cost of FNB to be like the FNA. So I think the future in Egypt will be FNB in the next years. I think so. And lastly, I thank you very much for the very, very, very nice, valuable, well-organized lectures. I enjoyed very much, and thank you really. There is only 1 minute, I think. There is only 3 minutes.
There is a question, Professor Hussein, for Professor Muhammad Osman. Fantastic lecture. What is your opinion or experience with wet suction? So this, as regards wet suction, what is the situation?
Yeah, so wet suction, it used to be a few years ago, it was like a fashion doing wet suction. Now it got replaced with slow pull. And I always say slow pull is less complex than wet suction, and it just provided the same results. So I stopped doing wet suction. Dr. Patel, you used to do wet suction before. What do you think about it?
We don't use it in Egypt, really. I didn't use it before.
Yeah, Dr. Patel, you are muted.
Unmute.
Unmute, Dr. Patel.
Dr. Muhammad, can
I'm sorry, I was interrupted by a call from the hospital. Can you repeat the question?
Wet technique. What do you think about the wet technique?
Oh, the wet technique just makes things wet. I think I have found that just using slow pull with the stylet has been more than adequate. It's also efficient. You're not doing the stylet's already ready to go and so on. So we did experiment with adding some saline and so on, but I have not found it helpful. Where I do use that, however, the only exception is for liver biopsy. We will use a dilute TPA to prevent excessive clotting on the liver biopsy. So there, I will introduce that and use it in that sense. But for standard pancreas mass or solid mass, I don't think it's particularly beneficial. The other benefit, I think, to the slow pull technique, we often don't realize when we're using suction, not just bleeding, but plugging of the needle. And so you may end up plugging the needle on your first actuation, and you may do 10 more, but actually you're not obtaining any more tissue after it's been plugged at the tip. And so I find with the slow pull technique, it's less of a impactful suction, and you're less likely to get that, and the tissue really stacks up very nicely within that. And the last thing I'll add is, we in GI, we often, if we see a mass in the colon, we don't brush it for cytology. We don't send a cytological aspirate. In the stomach, we don't brush a stomach mass. So I believe we should treat, solid masses in the pancreas pretty much the same way. And that's why as Dr. Othman nicely indicated, we do favor this. And also we have a very large country, as you may have heard. And it's different. It's very different in different places, as you may have also heard. And one thing we are trying to do is democratize the use of EUS throughout the country and make it so that patients don't have to travel long distances to get this type of care. And I believe that's where the biopsy also becomes advantageous, is in in areas where you don't have the pathologist. I think are more likely to get an adequate sample without having to travel to a very specialized center.
There is a last question, Professor Hussein, excuse me, if there is time, from Dr. Ghunaim. He's asking about in FNB regarding the number of passes. Do you depend on the macroscopic evaluation of the core? The macroscopic evaluation of the core? Yes. Professor Muhammad?
Yeah, so each pass, I look at the core, and you really want to see this nice, beautiful worms, and you also would like to see the tissue should have, it is white. You should see the whiteness of the tissue and some red. And I was in Hong Kong, and Anthony Teo, he was doing a very interesting study that after he get the core, he would spend time dissecting, removing the blood away from the core. And he just published his data after 3 years of doing that, showing that by inspecting the core macroscopically, separating the blood, you are actually getting much higher results.
Hello?
Yes. Thank you, Professor Muhammad, for this elegant and nice talk.